This lady is 57 years old, basically with heart failure symptoms. She is a diabetic, hypertensive, and came to us with heart failure symptoms, no angina. So the echo was showing an ejection fraction of 20%, and ECG does not show any infarct pattern, but shows an incomplete LBV. So with the view of the symptoms, we did an angiogram. You can see the echo, the RV systolic pressure is 50, and the CVP was engrossed. So these are the symptoms with which she came to us. Being a diabetic and hypertensive with the heart muscle thickness which was preserved, we did an angiography. So the echocardiographer told me that it could be diabetic cardiomyopathy. There is no evidence of clear-cut infarction. The regional wall motion is not there. So we did the angio. So we're going to show you the angio first. Can you hear me? Broken
yes,
connection.
We can hear you very clearly.
Okay, so now we can show you the the left coronary injection. You can see the circumflex is small, but there is a big OM which is totally occluded. Then there is a ramus which has a very tight stenosis in the mid part, and there is some osteal disease at the ramus, though not so tight. LAD can be seen to have a tight stenosis. Next, please. So you can see the LAD stenosis, and you can see a blocked obtuse marginal branch, which is quite big. Next. Next, please. And see the tight stenosis in the ramus artery, which is also quite big. Next. So this is the right coronary artery, which has a borderline lesion in the mid part. Then there is a collateral that can be seen filling up the obtuse marginal on the lateral wall. Next. So this is the right coronary injection again, and showing the collateral to the obtuse marginal branch. So the question here was, shall we offer this patient the revascularization? Shall we offer her optimal medical therapy with a device? If revascularization, surgery, or angioplasty? So these were the questions in mind, and a relatively young patient and is quite sick with heart failure. So we know this is a very controversial field of low ejection fraction, heart failure symptoms, whether revascularization is the optimal therapy or medical therapy based on the stitch data, and whether angioplasty can do things as good as surgery. So this was the case.
Thank you. It looks like a very complex case, and you are facing very tough decisions. Personally, I think that very probably the patient would benefit the most from a PCI, but all the lesions are very critical ones. Probably the easiest is the LAD, but if I could see it well from the LAD lesion, at least one huge diagonal is coming with a subtotal occlusion in the ostium with a very short bifurcation. Could you please show it to me? How the LAD looks like?
Can you show the epicranial again?
The LAD on the diagonal bifurcation.
Yeah, so I'll show you so the diagonal is diffusely diseased, and you can see there is a diagonal which is a reasonably big vessel. I don't think I will be able to do much to that. If I can protect it and save it from the harm, I would be more than happy. Because treating the LAD may compromise this diagonal, I know that. There are multiple septals coming in that area, and I can't compromise any of these.
Okay. So very probably.
My strategy was first to get a PET scan for this patient. So can we have the PET slide? Yes. Slide please. So anyway, the PET showed that the thallium uptake was there in almost all territories. There was no infarction. The entire muscle was hibernating, and there was about 20% hibernation. Even in the lateral wall, anterior wall, the thallium uptake was excellent. So in fact, we didn't have to, we did give FDG contrast, but even the thallium showed perfusion in almost all regions, which was very, very very good for us to know. And today we have started the case by checking the PA pressures. By checking the PA pressures, and PA pressures were elevated with the pulmonary systolic pressure of about 48 and diastolic of 26. So this is the PET, FDG PET. Next slide. Next, please. Next slide.
Next slide.
Okay, so the PET was very suggestive of a viable myocardium. So we started with a PA line and a contralateral femoral sheath for IABP if need be, and for a contralateral injection from the right. My idea was to start with this OM and then come down and do the LAD and then the RAMS finally. So this was the plan. So we started with the OM while the connections were being established. Can you go to the next frame? So I took a filter XTR wire with a crosshair catheter. Can you play this, please? Oh. So you can see there was double bend, and this wire was not so easy to cross, and crosshair had to follow this. So I first got the wire to go into the circumflex artery, got the crosshair down, and then probed this OM. So we recorded a live fluoro image to just show the same thing. So you can see the double bend. So I got the wire first into the circumflex, got my crosshair down, next please, and then slipped into the OM. So we did a contralateral injection from the RCA to show that the wire was in the true lumen, and we had crossed very well with the XTR wire. Next. So then I crossed the crosshair into the obtuse marginal. It went quite smoothly. Next. Then trapped the crosshair and changed to the cyan blue wire. Next. Dilated the lesion with a 2 millimeter balloon. Next. Then next. Then we measured the lesion. Next. Next. Which was about 38 millimeters. So I took a 2.5 40 biomine aura. Next. Next. And we can run the last one. Can you run the last? Just to show you, just to show it went quite easily, taking those two bends, and could be placed quite easily. Next. 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 So this is the stent. Next. Which was dilated, post dilatation was 2.5 high pressure balloon. Next. Next. So to do the stent optimization, we've done an OCT imaging. So we'll show you the OCT image. Can you see the OCT?
Now we see.
Okay, can you run it? Yeah. So most of the stent was very well reposed and symmetrically expanded, as you can see that. And we have one part, just proximal part, which is after the proximal edge, which was malopposed at this point. We went with the same balloon at a high pressure and got a good result. So this is the proximal vessel. There's no dissection. The distal part is also got no dissection. And next, please. This is next. Next. This is. I will take an angiographic shot to show this result, and then I go to the next LAD. So, any questions so far?
I think it's beautiful what you have done so far with the circumflex, and it's very nicely documented with the OCT. So we are happy to see that.
Cyan blue. Cyan blue.
So you go forward with the LAD, you said?
Yeah, LAD now. खराब तो नहीं हुआ? दो needle. 2.5 balloon.
Do Do you plan to treat also this high marginal, the first? I'm not sure from the screen whether it's significant or
Yeah,
not.
Yeah, it is significant. So I just plan to do a spot stenting in the tightest point. I don't want to go to the ostium.
Yeah.
Cranial. 2.5 balloon. Center.
Will you try to protect the diagonal or just deal with the LAD?
I may go to the diagonal. I'll show me the last picture again. I will take a wire to the diagonal as well.
It looks like a huge branch.
But I don't. Yeah, but I don't think I will be able to protect it even if I do the wire there. Wire then a filter XTR. Are you caudal? You can see that ramus or the early obtuse marginal 1 has a tight stenosis in the mid part.
Yeah, now we can clearly see it. Yeah, it's evident. What is the guiding catheter you use? Is the 6 French or 7?
It's a 7.
And the shape?
7 French.
And the curve is?
CLS3. CLS from Boston Scientific, curve 3. Similar to an ABO test.
Is that your preferred one, or is it because of the anatomy?
Because our hospital has a, so it's a something which we have not much control.
I understand.
So I have crossed the diagonal. I've left the wire there, but I'm still not sure if I'll be able to end the case with the diagonal still flowing. Balloon दूसरा दो Abbott.
What is the filter? The filter wire in the diagonal?
Yes, the filter wire in the diagonal.
And in the LED, just a regular?
So, no, I had taken a Xion wire, so I'm Xion blue. Patient is comfortable, the saturation is 98%. We have the PA pressures intermittently, which we are checking, have not increased really. Sure, connect. Text. Chalo, 6, 8, 10. 12. Down. OCT. OCT.
And the diameter of the balloon and the length?
Since
what kind of
so
a
the balloon was a 2.5 into 15. So it's a non-compliant 2.5 15 balloon. Oh, इसको दो needle again. इसको इस वायर का. Talker? Yes. Chalo. Test. एक मिनट एपिक्रिनल फ्रीज करना. ओके, OCT कैंथेटर. अब बिल्कुल हाथ नहीं लगाना, वायर खींच जाती है. So I'm going to size my stent based on the OCT, because the artery is diffusely diseased thereafter also. So there is a lot of disease distal to the lesion, so I want to be very precise in my diameter and the length of the stent. Okay, ready? Okay. Enable pullback. Start. Okay. इसको पुल उठाओ. Can you go distally? I want to see the distal vessel diameter. Yeah, just show me here. So, diameter. So we see the mean diameter comes to 2.5. Can you do some manual reading for that? Intima to intima. Can you do it again? From the media. From the media, external, next one. Yeah. Little bit forwards, little bit forwards, little more. Okay, that's fine. 2.8, fine. And now we measure the length of the lesion. Yeah, this would be normal. No, go little forwards, little more. Okay, go little more. Yeah, 28 would be all right. Yeah. So 2.5, 28. The proximally vessel diameter? No. No, you are measuring distal. I want proximal diameter. 28. 2.5, 28. So we have taken a biomime 2.5 into 29. So at a pressure of 14 atmospheres, I am going to deploy the stent to achieve what was 2.7 was the distal diameter from media to media. So that will ensure a proper sizing of the stent. Go up, please. 10, 12, 14.
What what was the diameter of the proximal LAD
So,
by OCT?
so proximal area is 2.9. By OCT 2.98. So I'm going to use a 3 millimeter balloon.
Okay.
Down. Three millimeter. 310. So the diagonal is still flowing, as we can see.
For a bit of surprise.
Yeah, but the septals are all intact. Since it's a filter XT wire, I may like to remove it before I post dilate with the 3. Hold. Hold it. Prepare. Okay, 10, 12, 14. So the non-compliant 3 to 10 mosaic balloon. Down.
At which pressure? How much you go off with the pressure?
14. 14 it was for the middle part. I'll go to 16 for the proximal part. 16. Down. दिखाओ. Okay, 14, 16. Down. 16. Down. OCT.
Do you use manual injection for the OCT or with the injector?
I use manual. I use manual. So with a 20 ml syringe, lower lock syringe. Pulse level. All pass. Okay. Syringe. How to calibrate? Okay, enable pullback. Start. I guess I missed the proximal edge. There is some malapposition on the proximal edge. We'll just see if we have to do it anything or not. Otherwise, the vessel looks pretty good. We'll calculate the MLAs. Distal part you saw, there was no dissection. Very well opposed stent.
For me, it looks fantastic. It's very well opposed. Yeah, here is some malopposition. Now we have.
Yeah,
There you
one
see that.
last 1 millimeter. Yeah.
Yeah. It seems we had some delay in getting the image, so we had seen this small malapposition at the proximal part.
Yeah, there's 1 millimeter of malapposition in the proximal part. I would take that, I would accept that. Otherwise, I have to take a 3.5 balloon, probably 3.25 at least.
Would it be possible to measure the vessel again?
Can you measure the malapposition? Measure the diameter? Yeah, we'll do that. Measure. No, measure the diameter at the proximal. So 3.7 is the maximum diameter there. So just proximal to the stent edge. And at the stent edge, I guess it is about 3.5. So if we have to correct this malapposition, I have to take another balloon, probably 3.25. I can take that, 3.25.
I agree. I would take it 3.25. Short NC balloon.
Yeah, 8, 12. Chalo. Light off. Okay. 16. 18. Down. Needle. So now we go to the obtuse marginal, high obtuse marginal 1.
With the short spot stenting.
Yeah, short stenting. 2.5 balloon.
Up to the moment, the amount of the contrast
So this is
used
fine.
here, how much it is? The contrast.
Okay, so contrast kitna use हुआ? So I have not taken too many injections. I have done all OCT runs. So about 160 ml of contrast has been used so far. Are you called? I think another 40 and we'll be able to finish this case. Stent 2.25 18. Eliocaudal. Test. Two millimeter balloon. Ariocaudal.
2 millimeter balloon. Balloon.
2 millimeter. 2.25 18.
2 millimeter.
2.2 millimeter.
213.
2.5 है हमारे पास 2.5.
2.5. 2.5.
हाँ दो
15
ये
है
कौन सा है मोज़ेक ये एबलेट center. Okay. 3,000 heparin. 5,000 दे दो.
5,000 sister.
6, 8, 10, 12, down. Six, 8, 10, 12. Down. The 2.2580. So we can see the disease start from the ostium actually.
Yes, and the balloon created a huge dissection. So would you change your
Yes.
strategy to stent it from the ostium of this marginal?
Yeah, I'm thinking so because it is an ugly dissection and the disease starts right at the ostium. So
Yeah.
can we see the ileocaudal? Two point 2.25, 28. So I'm going to start from the ostium.
Yeah, it's a very nice projection for the ostium.
28. See the second obtuse marginal, which was totally occluded, has become a very big vessel. $29. Hold it. So we are taking a 2.25 into 29 Bioman.
Here in the panel, we notice that the left main in this projection is mildly diseased, maybe. What do you think about the left main?
Yes. Yes, we saw that, and we have seen that on OCT. The first view was, we visualized it, it had a huge MLA. MLA was about 10, 9 point something. So I had looked at that and realized that, but the MLA was good and there was no plaque, which was abutting that area. So I am. Double MAC. So the stent starts just after the marker. So would you be happy with this position?
Yeah, it looks very good and very stable. The stent is not moving.
But working such
Go up
close to
10,
the ostium
12.
of the circumflex, maybe another wire in the circumflex as a protection.
Yeah, but I saw that it was very big, no plaque there. Angle was good. I don't suspect any problem to happen. You never know. Down. Double mag hata do. 2.5 balloon. So we have covered the ostium, so I'm going to do post-dilatation there for sure. Ariocaudal. Table a little up. Light off.
What is the size of that balloon? Is it an NC 2.5?
Yes, 2.515. 16. 18. Down. 18. 20. Down. दिखाओ. And I would definitely like to do an OCT at this ostium. Look at the ostium, the stent has not even flared up at all. 20.
Yeah, it seems that the position of the stent
22.
is very good. It covers the ostium but doesn't protrude to the circ.
Down. दिखाओ. Okay, 12, 14, 16, 18, 20, 22, 24. Down. OCT.
Yes.
That looks good. The floor safe.
Sir, just a moment. Hold back.
Show the system.
I think it was a good decision to cover it from the ostium. It looks much,
Yeah.
much better now.
Okay, enable pull back. Start. We'll show you the left main also in this, whatever we see. There is a distal dissection now. Just so we'll have to measure how much is the distance. So this is a deep dissection. I think I may have to cover this. Go on. Run, keep running.
It seems that the plaque was a bit longer distally and it made some dissection at the edge of the stent.
Yeah. Right. 2.25, 15 or 18. Lineage में देखो. अरे 16 then. See, the left main is fine. So the impression that
Yeah, the OCT of the left
it's
main
more
is,
than 10 actually.
yeah. It looks much better in OCT than on the fluoroscopy with angio.
So I'm taking another stent which is 2.25, 16, another biomine, and you saw that the proximal part of the stent was very nicely covered at the circ. Can you show the proximal edge of the stent? Yeah. So you see the proximal part is just at the circumflex.
Yeah,
So it's nicely placed.
it just covering the ostium. It's beautiful. And the stent opposition is also very good for the whole segment.
Yeah. So I'm taking a 2.25, 16, another biomine to cover the distal part. Prepare. I'm not going to go to, I go to 10 and then pull the balloon and dilate further. Okay, go. 10. Down. 16. 18. Down. OCT. So we'll take a final OCT run and wait for your comments.
Okay, we'll do.
Pass la. Okay. LAO caudal. Enable pullback. Start. I just want to concentrate on the distal stent. Vessel is rather small, and there's no dissection now. It's
Okay.
a good transition between the distal stent and.
Yeah, it covers the whole.
So I'm quite
dissected.
happy with this. So there's no flap now. So I think we would be happy with this result and hope she does well. PA pressure. So the PA pressures have gone up a little bit, the contrast effect, so we give her some diuretics. The PA pressure is now 56 by 42.
How much was it when you started the procedure?
So when we started, it was 48 by 32.
Oh, yeah. And you ended up with about 200 cc of contrast?
220. 220.
Oh, yeah.
Last start karo. 10 mg per hour. एक एबीसी करना हो गया बंद हो गया खत्म हो गया
Dr. Balbir, this is Pratik here. We have last 5 minutes, and if there are
Yeah.
any questions, they will ask you.
yeah
Okay, so or you can ask them, and then
yeah
we
but
can
I
close
wasn't
it.
able to hear
Yes, I'll
Yeah,
put
you
it
can
to the
have their
moderator.
comments now.
Yes, yes, okay.
Okay, so Dr. Singh, congratulations to this excellent case. It was very educative for both the revascularization strategy and also for the PCI itself. So I'd like to congratulate you and to your whole team for this beautiful procedure.
Thank you so much.
And I'd like to ask the audience and my partners at the panel whether anybody has questions.
From the audience, I think that some questions you have to have some questions. One question from the panel about the finalizing the procedure with the catheter. I mean, for the femoral approach, are you going to close it with a closer device, or will leave the introducer and manual compression after that?
So I'm a little worried that whether we will need to insert a balloon pump or not because of the PA pressures.
Yeah.
So I will leave her for next 2 hours
Okay.
just for observation that we have kept the balloon pump standby. So I don't want to close and get into, she gets worse with her heart failure symptoms. So that's why I'm keeping the sheath.
Okay, perfect. Yeah. What do you think about the pressure? Why the pressure is down now? I mean, she started with a...
No, the pressure is fine. That's the pulmonary artery pressure that was I'm mentioning. Her pressures are 120 by 80, saturation of 98. She's very
Okay.
comfortable.
Okay.
That was the pulmonary artery pressure that I was telling you.
Questions from the panel, from the for the strategy, for the three-vessel revascularizations, the idea about OCT, how helps because adjunctive technology.
Hi, can I just ask you about the strategy that you've employed here? Sort of the Euro 2 score is about 3.2. I guess the syntax score is in the intermediate range. Was there any disease in the right? I didn't quite see that. And a diabetic young patient who's got poor LV, just wondering what sort of led you to the PCI strategy?
Dr. Singh, could you hear the question?
No, I couldn't.
Okay, so we had a
I
question.
couldn't hear the question.
We had a question from the audience about the implantation, about the revascularization strategy. So for a complex left coronary artery disease, poor ejection fraction, and diabetic patient, our colleague wanted to ask whether the cabbage would have been an option for this patient.
Yes, the cabbage is definitely an option for such a patient. I think the reasoning is it could be individualized to the patient's family and the person who's doing the angioplasty. If we can achieve this kind of a result with angioplasty, I'm sure with an optimized by an OCT, I'm sure the MACE rates are going to be low and we have a competitive procedure against surgery. So in this patient with such poor LV, with high PA pressures, even the surgical mortality is pretty high. It's about 5 to 10%. So the family was not willing to take that risk and wanted a non-surgical procedure.
Okay, I completely agree with you. I have the same feeling. Okay. Any other questions we have? Okay, so Dr. Singh, thank you again for this very educative case. We enjoyed it a lot.
Thank you so much.
Okay, thank you.
Thank you. I thank all of Brijesh, my team, Amit, Dubeji, all the people who helped me do this case. Thank you very much.
Thank you.